This week we'll be talking about psychosocial health concerns for women. Now, there are so many topics that I wanted to address in this PowerPoint, and ultimately I basically decided to narrow it down to just really hone in on anxiety and depression, and then I touched base just a little bit on bipolar disorder, but primarily anxiety and depression. And obviously there's quite a few more health concerns in addition to these, so I would really encourage you to dive into your book and go over PMS and PMDD some more, and eating disorders especially. And I know that Julianne's done a fantastic job of covering issues around violence against women. So there's so many directions this could go, but basically the point of this PowerPoint is going to be to go over anxiety and depression. So mental health in primary care, here's some general principles. So we want to use simple screening tools because then we remember that we can use them, right? So it doesn't help to have really complicated tools if we don't have access to them or don't know how to go about it. And while I don't make this a hard rule, not prescribing drugs on your first visit is really a good rule of thumb. Basically, we want to be doing the screening, and then if it looks like somebody's being diagnosed with something for the first time, referring them for further evaluation would be warranted to have really thorough, not just screening, but diagnostic testing around what's going on. So not a must, but really something worth considering. And then ideally we don't want to prescribe controlled drugs as often as possible. And in general, we don't want to prescribe medications for grieving. Grieving can be healthy and it's also situational. So definitely keeping a close eye on those moms and women, but not jumping right to medication. And then finally, wanting to especially keep a close eye on women who are already dealing with other chronic illnesses, because definitely their risk for mental health conditions and disorders would increase with that. So let's start with anxiety disorders. Anxiety disorders are the most common psych disorder in the U.S. So over 40 million Americans is diagnosed with something on the anxiety spectrum every year. They have a substantial impact on people's social as well as their work lives. So there's about 10 different types of disorders that are considered anxiety disorders on the DSM-4 list. So that ranges from generalized anxiety disorder to OCD, panic disorders, etc. So I'm just going to go through a couple of those here. And just to keep in mind that for anxiety disorders, they need to last at least 6 months and in order to be diagnosed, and then they're going to get worse if they're untreated. So this isn't something where somebody has a panic attack one day and that's the only thing we ever see. These are ongoing issues. So for anxiety, okay, so in general we're thinking of it as people who are, their apprehension to things is disproportional to the actual stimulus. About 25% of the general population is the lifetime prevalence. It does affect females more than males. And here's a few clues in primary care that can kind of hone you into wanting to explore anxiety further. So first, these women often present with multiple somatic concerns. So when you're doing your review of system, there's just like a lot of little things here and there that aren't quite right. So maybe it's insomnia on top of having stomach aches, on top of having headaches. So that's something to explore further. There's patients tend to rate their symptoms as being pretty severe, and they tend to rate their general health status as being lower. And then in general, as a provider, you might consider it to be a difficult encounter. So tricky making eye contact, anxious patient concerned about a lot of things related to their health, etc. It just for yourself socially, it might be kind of a tricky visit. And then certainly the age of the patient, younger would be at a higher risk, so less than 50. So here's a good screening tool. This is the GAD-7. However, you could do a GAD-2 or a GAD-7. So a GAD-2 would just be rating these first two questions, and a GAD-7 would be rating all of them. you can see the first question, feeling nervous, anxious, or on edge, and then their rating is based on how often that happens. Second question, not being able to stop or control worrying. So even if you don't remember anything else, if you can know at least those first two questions, then you don't even have to look up your scale. But I think these are the kind of scales that would be great to put in your little pocketbook so that you have access to it easily in clinic. So here's your GAD-7, and then you can whip it out as you need it. So those first two, if all you do is ask the first two, if their rating is 3 or more, then that would be a positive screen for thinking about panic disorders as well as generalized anxiety disorders. So, and all of these are within the last 2 weeks, have they been having these experiences. So, yep, so that's the GAD-2, and then the GAD-7, if you ask all questions, so tagging on to that, worrying too much, trouble relaxing, being so restless it's hard to sit still, becoming easily annoyed or irritable, feeling afraid as if something awful might happen. All of those, if the total score is 8 or more, then that would be a positive screen as well. So GAD-2, GAD-7. And then the positive predictive value of doing this screen is somewhere in the 20s percentile. So just because you have 8 or more, that doesn't mean that person does have generalized anxiety disorder. However, the negative predictive value, say you have somebody and you're wondering if they might be suffering with generalized anxiety disorder, and say they score a 6, so it's not a positive screen, the negative predictive value is in the 70%, 75%, in that kind of a ballpark. So it's more telling if it's negative than if it's positive. Just because it's positive, that doesn't mean that they have generalized anxiety disorder or a panic disorder. So anxiety workup in general, we want to do a thorough history and physical, especially highlighting neuro, thinking about vertigo, thyroid, so especially hyperthyroidism, right? Which, depending on a condition somebody might have, like say a woman has Hashimoto's, ultimately that's a thyroid function going downhill, right? But when antibodies are attacking a woman's thyroid, and just so you know, for hypothyroidism in the United States, that's the most common reason. Hashimoto's is the most common reason for hypothyroidism, whereas out of the U.S. or in developing countries, it would be iodine deficiency. So say a woman has Hashimoto's, if antibodies are attacking her thyroid and her function is decreasing, her thyroid might put out shoot out extra thyroid hormone kind of in waves trying to compensate for it. So these women might have symptoms of both hypothyroidism and hyperthyroidism. And I'm digressing. I apologize. This is not a lecture on thyroid. Okay. And then also wanting to hone in on cardiovascular and respiratory. So especially if they're presenting with issues like my heart's racing, or I can't breathe, we want to make sure that it's not that they have a dysrhythmia or that they have asthma, right? So I'm wanting to rule those pieces out. So labs, CBC, CMP, TSH, kind of based on what their presenting symptoms are. And then there's your reference for the GAD scoring. So a GAD-2, 3 plus would be thinking about GAD or panic disorder, and then for the GAD-7, 8 plus. Oops, and I spelled that wrong here, sorry. Okay. And then realizing that 40% of patients with anxiety also have depression. So if you're having a positive screen on the GAD, it would probably be worthwhile exploring depression screening as well. Not probably, it would be. Okay, so immediate treatment for generalized anxiety disorder. Benzodiazepines can get us through the initial hump. So we want to limit them to probably 2 to 4 weeks or so, but basically until we can put other medications on board that take a while to kick in, this can get us through the immediate issue. So you could do lorazepam, Xanax, Klonopin, and that's one where it's just kind of easy to look up your dosing on the spot, I think, rather than doing a lot of committing to memory. So much as understanding that you're giving it on a PRN basis. You know, they can take it probably 2 to 3 times a day as needed. And then that we want to give them enough pills to last them somewhere in the 2 to 4 week realm until their other medications can kick in. That's not where we want to stay because it can be addictive. Another option that also has good efficacy behind it would be something like hydroxyzine, which is a sedating antihistamine, so that would be an option. And then self-help and support and education, all of that's kind of going to come around this too, but really I don't know that I would consider that immediate treatment. So long-term it can help for immediate issues, but isn't, that's a little bit more of a long-term commitment there. Okay, so long-term treatment. So psychological therapy, and we're not going to have that on our shoulders to take on as clinicians. And then antidepressant medications. So we want to consider age, previous treatment, risk for overdose, tolerability, preference, cost, all those pieces that come into making a good drug choice. But basically we're thinking like an SSRI, such as Lexapro or Paxil, or an SNRI generally is going to be first-line treatment there. And you want to try it for a minimum of 12 weeks before giving up, but ideally really continuing for 6 months before considering tapering off. So wanting to treat for a good 6 months before thinking about backing off based on how she's doing. And then panic disorder, and actually I should have mentioned, well, okay, at the very end of this presentation I get into some of the complementary pieces, but yoga is really great for generalized anxiety. Yeah, we'll get into that later. Okay, moving on. So panic disorder would be recurrent unexpected panic attacks with at least one attack followed by at least 1 month of 1+ of the following. So persistent concern, worry, significant change in behavior related to attacks, such as not wanting to leave their house, avoiding certain social situations, that kind of thing. They tend to have 10 to 15 different somatic complaints. So chest pain, rapid heart rate, feeling dizzy, having a headache, stomach ache, breathing difficulties. So a lot of different symptoms coming around this. It would not be related to a direct physiologic effect. Sorry, I should have proofread this a little bit better. Okay, so for example, if somebody's over 40, we should do an EKG because we want to make sure their heart's not racing because something else is going on, right? So if it's a panic disorder, we can't have a physiologic cause for this. It's also not related to another mental disorder, so it has to be isolated to just this. And basically, your workup and your treatment is going to be pretty similar to GAD, which we've already briefly gone over. Okay, so at what point for GAD or panic disorder would we want to think about a referral? So any of our patients that are suicidal, that would be worth immediately referring and considering inpatient definitely. Failure of 2+ first-line treatments. So if you've already kind of played around with it and we're not making much progress and we've given medications their decent amount of time to start working and we're still having issues, then that would be worth referring. And then if we're not leaving our house, and basically agoraphobia, I'm getting it if this is just really severe. I like to say that we treat the garden variety, and we're the gateway keepers for understanding if people are needing more help, but we're not trying to treat the most severe, most complicated of everything, right? So if we're having a lot of issues, then we can pass women along and stay their primary care providers, but not the main people managing severe conditions. And then if they just have significant life stressors and really limited support, same thing. So coming along the same lines there. Okay, so PTSD would also be considered like on that anxiety spectrum. And your mnemonic here is DREAMS, to put in your little notebook that's in your pocket when you're in clinic. So DREAMS would be they're feeling detached and they're having re-experiences of the event, emotional distress, avoidance, months duration of symptoms, and then sympathetic hyperreactivity or hypervigilance. So I'll give an example. One of my friends recently, her dad had a heart attack in the shower and she was the only one home, and she called 911 and started initiating CPR, and he ended up dying. And she was a nurse, and that brought along a lot too. And it's been months and months since that happened. But if you see the diagnostic criteria there, she often has flashbacks to that experience, so they're re-experiencing the event. It comes to her often when she doesn't want it to. She finds herself avoiding the bathroom that he died in, which is kind of hard if you're living in the same house still. And then hypervigilance. She's living with her mother currently, and she finds herself often kind of jerking awake in the middle of the night and feeling like she needs to go check on her mom. And she's had these symptoms for more than a month. So based on those pieces there, that would fit the DSM-4 diagnostic criteria for PTSD. And interestingly enough, more women than men have PTSD, which was actually a little bit surprising to me given our veterans. But this is definitely something that's a burden for women and thinking about women's health. Okay, so PTSD treatment, safety, wanting to ensure that their current location is a safe place, so that really it's the post-trauma, they're not at risk for current trauma, right? And then education, especially about triggers, thinking about how to put them in a place that kind of shepherds them and keeps them safe, and what to do when they have triggers, but being able to avoid triggers especially. But I guess I should say, yeah, being careful about that, avoiding triggers, but not in such a way that it's impacting your life negatively in a way where you're encouraging avoidance. And then therapy, that can be in or outpatient, and then pharmacology. Basically, what kind of symptoms are they having related to the PTSD? Is it anxiety? Is it depression? Is it insomnia? Wherever they're falling on that spectrum, that's what we're treating from a primary care angle. And then sertraline, so Zoloft or paroxetine would both be good options too there. Okay. So getting into mood disorders here, I think this is an excellent graph. So this would be an even keel mood, so with a normal amount of fluctuation. Maybe I like to think that there can be little waves in here, but not to the extent of cyclothymia. So in general, we want people to kind of be on this line. And again, I don't want to imply that that's really a flat line, because life has its ups and downs, and having ups and downs is part of life, right? But somebody who's suffering from cyclothymia, their ups and downs are to an extreme. Now, not to an extreme like bipolar disorder, but there's an extreme to it that's outside of, I guess, what we would consider a normal range. Dysthymia is where we have ups and downs, but all the ups and downs are still kind of on the spectrum, or the average line, rather, is lower than what we're calling a normal line. And then for bipolar disorder, you can see that here's our mania, and here's our depression, and bipolar 1 would have this all the way up to the mania, whereas bipolar 2 would have kind of a hypomania, which we'll talk about in a little bit. And then if we're just talking about depression, then you're on the normal path, and then you go way down and then up again, and then you're back to the normal path. I find that graph really helpful. Okay, so major depressive disorder. So multiple medical visits, they tend to have a few different things going on. So maybe it's weight gain, weight loss, sleep disturbances, fatigue, irritable bowel syndrome, a dampened affect, not that they're presenting for that, but just to think about the myriad of things that they might be presenting with. And a lot of them might be unexplained symptoms, so same ones I just mentioned. So there's often work or relationship dysfunction related to it. And oftentimes we think about people being depressed because of work or relationship dysfunction, but really with true major depressive disorder, it's that the depression is impacting work and their relationships, not vice versa. Certainly there's a little bit of an interplay there, but ultimately with major depressive disorder, that's what came first. So with major depressive disorder, 8% of women at any given time would have symptoms that would point to that direction. And then 50% of women will experience symptoms like this at some point in their life. Not that it becomes fully diagnostic for MDD, but to recognize that this is a common concern within women's health. And women actually have a nearly twofold lifetime prevalence compared to men. Okay, actually maybe I'm getting ahead of myself. Well, we'll do that first, I suppose. So it disproportionately affects women. So, so women have a nearly twofold lifetime prevalence. There's no difference between men and women prior to puberty, but then starting at puberty, women are at a higher risk for depression, and then that continues through menopause. And then for postmenopausal women, those levels start to normalize with men again, but never fully. So that's kind of the spectrum there. And they're particularly at risk during puberty, postpartum, and menopause. So that's related to just shifts with estrogen and progesterone, both of which can impact serotonin, norepinephrine, and dopamine. So basically it's altering their feedback loops. So both progesterone and estrogen can have a role in that. So I won't go into too much detail there, but and then it's also disproportionately affecting minorities, so particularly Hispanic women, but basically white or Caucasian women would be the least at risk. So as we've seen, many women struggle with this at some point in their life, but being aware that it does disproportionately affect minorities in the U.S. All right, and irrespective of life events, that kind of gets back to what I was saying with which came first, your work or relationship dysfunction. So it's not that life events are causing this. This is chemical imbalance that's happening intrinsically regardless of life circumstances. Though certainly, I mean, you want to say it like it's black and white, though it never is fully black and white, right? So certainly having a lot of life stressors and not having as many coping mechanisms in place in your life can aggravate what's already there, certainly. Okay, and then we already alluded to chronic illness and substance abuse earlier as having a higher play with mental health disorders. Okay, so risk factors for depression in women. So we have the hormone fluctuations, multiple social roles. Women in just about every society bear a lot on their shoulders. Increased risk for early trauma as well as ongoing risk for recurrent trauma related to revictimization. Comorbid psychiatric disorders would put women at a greater risk as well. And then also increased neuroendocrine disorders. All right. So depression, cause and effect. So mental illness is often the cause of life stressors rather than the result. So we already touched on this. So unemployment, marital problems, financial problems, drug and alcohol abuse, social isolation and withdrawal, all of those things can happen as a result of depression. And if there is alcohol abuse in the mix, that'll interfere with med efficacy too. So understanding all the dynamics around comorbidities there. Okay, so screening tools. 2-question screen, that's a good one to just memorize. And then other ones you can do your best to memorize it and then also put it in your notebook. So our 2-question screen is, over the past 2 months, have you been bothered by little interest or pleasure in doing things? So that's known as anhedonia. And then feeling down, depressed, and hopeless. So that's your 2-question screen. And then SIGI CAPS is a good mnemonic to memorize. So the S is sleep. So has there been any change in your sleep pattern lately? Interest, you could say, have you lost pleasure in your usual activities? Guilt, do you feel worthless or do you have inappropriate guilt in your life right now? Energy, are you feeling more fatigued? Are you tiring easily? Concentration, are you having difficulty concentrating? Has there been a change in your appetite? Do you feel restless or have a difficult time remaining on task? That would be the psychomotor there. Suicide, Have you felt like life is worth living? Have you considered ending your life? So if you can memorize SIGI caps, that's a great screen as well. And then we also have the PHQ-9, which is coming up in the next slide. And then Zhang's self-rated depression scale would be another option there. That's a website. All right. So I'm going to just blow this up, which I know is hard for everybody who printed this out. But we'll just do this for the video. How about? Okay. So over the last 2 weeks, how often have you been bothered by any of the following problems? So it's similar to the GAD, where they have several days, more than half the days, nearly every day. And all of these symptoms are going to look similar to our SIGI caps. So little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling or staying asleep, sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself or that you're a failure, you've let yourself or your family down, trouble concentrating on things, such as reading the newspaper or watching television, moving or speaking so slowly that other people could have noticed, or the opposite, being so fidgety or restless that you have been moving around a lot more than usual. And then suicidal ideation is the last one. So that's a good screening tool you can use as well. So some of this too is thinking about primary care, right? Not just pulling these out when people are presenting with symptoms, but what can we be doing routinely? Maybe you see that your routine questionnaire doesn't address mental health at all. Maybe just putting in those 2 questions, and then on their health screening questionnaire that they fill out in paper in the lobby, and then if you see that either of those is positive, then you do a full SIGI caps when you're in your visit. So how can we be slipping this in for prevention as well? Picking it up even if they're not bringing it up. Okay, so something that really needs to be addressed if we're going to be screening for depression is that we also screen for bipolar disorder. So 70% of patients are misdiagnosed with unipolar depression who actually have bipolar disorder. So we're screening for the depression, but we forget to also screen for the manic side to ensure that it really is depression. So we're the gatekeeper for that. Like if people are seeing us for their annuals, we're the ones that need to kind of pick up on that and refer people accordingly. So I don't know, I think an easy way to get into it is looking back on your life. Have there ever been any periods where you've had a lot of energy for 2 to 3 days? Maybe you've had really little sleep but no fatigue. Periods in your life where you've been particularly irritable. So elevated or irritable mood for 4+ days, and then thinking about for mood disturbance having 3 or more of the following. So inflated self-esteem, decreased need for sleep, more talkative, flight of ideas, thoughts racing, distractible, increase in goal-directed activity or agitation, excessive involvement in activities with potential for consequences. All right, so that's all I've got on that. Okay, so make sure we're screening for bipolar disorder if we're also screening for depression. Okay, so here's the DSM-4 diagnostic criteria for major depressive disorder. So at least 2 consecutive weeks of either depressed mood or a loss of interest or pleasure in nearly all activities, so that has to be there, with at least 4 of the following additional symptoms: appetite or weight change, sleep disturbance, psychomotor activity, decreased energy, feelings of worthlessness or guilt, difficulty concentrating or making decisions, recurrent thoughts of death or suicidal ideation. And then that's going to be accompanied by significant distress or impairment in social, work, or other areas of function. So if they're reporting all these things but they're not really impacting their daily life, then there has to be kind of an element of severity to it. These symptoms need to be persisting for most of the day for 2+ weeks. So anytime we're talking about depression, we also want to make sure that we're fully screening for suicidal ideation. So is this patient risk to self or others? So do you feel that your life is worth living? Do you wish that you were dead? Have you thought about ending your life? And then if yes, Do you have a plan? Do you have access to carry out your plan? Are you thinking about hurting yourself or others? So making sure that we're doing a full screening there and that we're referring as appropriate. And that's not something that's done in primary care, especially among adolescents and the elderly who are at the highest risk. So both depression screening as well as depression screening as well as suicidal ideation are particularly lacking as far as our screening goes with primary care, and something that we need to be improving on. And if you do have an adolescent with a suicide risk, that's just an automatic referral. Less than 24 with meds, you probably don't want to be managing that yourself. Okay, differential diagnoses for depression. So you can see there's a whole slew of them there, and especially touching on ones where there might be an overlap in symptoms. So anemia, that could be responsible for our fatigue. Hypo or hyperthyroidism, common comorbidity as well. So doesn't mean we wouldn't necessarily be treating depression, but wanting to find if there's a cause for what's going on. All right. So lab work, thyroid function, CBC with differential, thinking about anemia, electrolytes, creatinine, liver profile. Some of that just has to do with what medications you might start them on. So liver function tests would be a good example of that. I'm not saying you need to do all of this if you're thinking about starting somebody on a medication or screening somebody for depression, but that you consider all of these. So a pregnancy test might not make any sense, but would be worth considering, for example. Same with the drug screen. Okay, depression treatment. So this is an important slide. First, let's think about the trajectory of depression. So full treatment for depression would be a 12-month course of antidepressants, so no less than that. And even with that, there's a 50% chance of a relapse if somebody has a depressive episode. And then if they have a second episode, there's a 70% chance of relapse. And then if they have a third episode, it's highly likely that they're going to have another one, basically 100%. So we know that we're going to treat for at least 12 months initially, but say somebody's had 2 episodes with full treatment both times, that might be worth considering just keeping them on their medication long term, because there would be a 70% chance of relapse, for example. So we're keeping in mind depression's natural trajectory when we're considering when we're starting people on meds, how long we're keeping them on meds. Medication dosing, basically we want to start low and go slow. Most can be given once a day, so that's obviously a lot more convenient. You think about people who are having a hard time getting out of bed and where showering is a big chore for their day. If you're asking them to also take a pill 3 times a day, what are the chances that that's going to happen? And again, we're giving it for a minimum of a year, and we might need it long term. And then we're wanting to always make sure that we're watching for behavioral activation without mood improvement. And I know you're all nurses, so a lot of this is review, but just being aware that, somewhere in the 10 to 14-day realm, like say with an SSRI, they're going to start to have energy improvement, but their mood won't necessarily be improved yet. That can take, 4 to 6 weeks. So if you have somebody who's at risk for suicide, they might finally have the energy to carry out their plan, and they'll have that energy before they start to have the cloud lifted so they can start working on their stuff. That's how I like to think about antidepressants. It's not going to be our ultimate fix, but sometimes we need something to help us kind of clear away the clouds so that we can work through what's going on. And until that cloud is cleared away, they can actually be at a higher risk for suicide when they initially start their antidepressant. So that's something we need to watch for. And then usually the patient is the last one to know that they feel better. So you'll oftentimes hear family saying that they've really been improving before you would actually, the patient would realize that themselves. Okay, another really important slide. So phases of treatment, and then this also kind of gets to the trajectory of the illness again. So up here at the top, this is what we're considering to be normal, a normal mood. So we have depression, we start to have some symptoms, and then we have the full-blown syndrome down here. So below this line is we have the full-blown syndrome where we meet all the DSM-4 criteria, right? So then we start to do treatment. Okay, so treatment starts here, and then we start to pop up, and then they start to notice that they're having fewer and fewer symptoms, and then right around this X, they're likely to stop taking their medication, in which case we would go right back down. So realizing that once they start to feel better, that's not the time to start tapering off, or we're just going to go back down again. So up here we have response. So response would be considered about a 50% reduction in symptoms. And then if we keep coming up here, we want to make sure we're continuing to take our medication. So this might be another place where basically back to normal. People want to stop taking it and start tapering again. And then we're at risk for really relapsing again. So ideally we're keeping everybody on till we hit remission. So remission would be 100% reduction of symptoms. And then we want to reach remission and then get all the way to recovery. So again, somewhere in the remission to recovery, we're going to want to stop taking our medications. But recovery really is 6 to 12 months of remission. So ideally, we don't stop taking antidepressants until we've been symptom-free for a year. And then, let's see here, what else was I going to say? So relapse, we might get worse before the end of the remission period. Okay, that's good to note. Got a couple notes in here. Oh, and then recurrence would be considered a new episode altogether. So anything before this recovery period is considered a relapse, not a recurrence, as in we haven't fully recovered and we're coming back down again versus episode number 2. So take-home message here is we're not putting people on antidepressants for a couple months till they feel better and then starting to taper off again. If we're really trying to treat for depression, then full treatment's going to be at least a year. Okay. Next couple slides are kind of busy, and I apologize for that. So depression pharmacotherapy. So this slide is looking at SSRIs and SNRIs, often our first-line treatment for depression. So they're great, about a 70% success rate. Pros for SSRIs, minimal toxicity in general, pretty easy administration, generally safe in overdose, with the exception of the serotonin syndrome. Cons, so side effects, nausea, insomnia, weight gain, sexual dysfunction. So Paxil packs on the pounds, that's your mnemonic there. Paxil's the one that's most known for that. And you'll find with all of these medications, it's like, oh, the pros for that one are great, but oh, the cons, that's kind of unfortunate. There is no perfect medication in the antidepressant realm, which is tough. So, so nausea, about 20% of people, if that kind of helps give you a frame of reference. Weight gain could be up to 20 pounds. For sexual dysfunction, erectile dysfunction is a really big deal. Obviously, we're just really focusing on women, but it can really affect their libido, so that's something to consider. And that might be something where we decide to stop the drug and try something else, or take a mini drug holiday, or have an adjunct therapy. So I think of that more so with men if you want to also treat the erectile dysfunction, that kind of thing. Or think about switching to a medication like Wellbutrin that doesn't have the sexual dysfunction profile, that kind of thing. Serotonin syndrome is basically, usually it would come on several hours after having like a new increased dose or starting it for the first time. Might be sweating, headache, agitation, confusion, tachycardia, and then if it's really severe, it might be a high fever, or even seizures or unconsciousness. So not common, but something to be aware of if you're prescribing an SSRI. So SNRIs, maybe I'll talk about Effexor. So Effexor, a pro for Effexor is that it's got low protein binding, so that's kind of nice, safe in an overdose. indicated for both depression as well as anxiety, generalized anxiety disorder, so that's a pro, that it works well with both, not all do. Cons, it can increase blood pressure as well as heart rate, and it's got a pretty wide dose range, so kind of hard to find the perfect spot sometimes. And it's also BID to TID dosing, so that's not ideal, and it can cost a little more. Similar side effects to the SSRIs, with sexual dysfunction being on that list. And then just as a quick pearl, SSRIs, Prozac. Prozac's probably your best choice for pregnancy, and Zoloft is probably your best choice for postpartum. Granted, we don't like jumping around from med to med, so ideally we're picking one and sticking with it if we need to be on it. And this class is women's health, so I'm going to turn off my pregnancy right there. Okay, let's talk more meds. So atypical antidepressants. Wellbutrin's kind of nice. I worked in a clinic for a while where we did a lot of smoking cessation counseling, and Wellbutrin is great in that department. You can be prescribing Wellbutrin for that purpose. So if you do have somebody who is struggling with depression and they smoke, I would definitely consider Wellbutrin. So pros, there's no side effects related to sexual dysfunction as well as weight gain. Weight gain's not an issue for this. So, and then the smoking piece. So that's a pretty good side effect profile. Cons, it tends to be more frequent dosing. There is a seizure risk there. And there is, okay, so in general, we don't recommend Wellbutrin for people who are also struggling with anxiety. Literature isn't fully clear on this, so I don't want to present that as being a black and white thing, but in general, Wellbutrin tends to make people a little bit more anxious. So for the 40% of women who are anxious and also depressed, Wellbutrin's not your best choice. So if it's purely depression, Wellbutrin's great. I actually really like using Wellbutrin with my patients. All right, next up, we've got, let's see, when we would talk about trazodone. So trazodone pros would be sedation and minimal side effects. So a lot of these medications, one of the side effects is insomnia, which isn't helpful if you're depressed, right? So sedation can be a plus there. And then cons, orthostatic hypotension, not the end of the world. Kind of a weak antidepressant, not generally speaking a go-to for first line. Like Wellbutrin could be an appropriate first line. SSRIs, SNRIs are generally more commonly your first line. Okay, tricyclics. So tricyclic antidepressants, or TCAs, is what you'll also see them called. Pros would be lower cost, and the efficacy is good. So we want to be keeping in mind all those pieces for our patients. And if it's going to be hard for them to stay on a medication that's a little bit more expensive, you might want to consider a TCA. Cons, orthostatic hypotension again. It can be lethal in overdose, and it can be sedating, which could be a pro or a con, I suppose. High suicide incident rates for adolescents for TCAs. And then thinking about the elderly, we can have an increased cardiovascular disease risk as well as constipation. So just kind of being mindful of what side effect profile you're giving people. And now's around when you're wondering why we're recommending these at all. But they have been shown to be effective in helping get all our side effects in a better place. I didn't mean side effects, I meant symptoms of depression. So, okay, and then MAOIs, basically these are going to be your last defense, and I personally have never prescribed one. I would be referring somebody on before we would get to this point. But hypertensive crises is a risk, serotonin syndrome is a risk, and you have to be really particular with your diet, so they're avoiding the tyramine foods. This is all probably coming back from nursing school, where you're all just really familiar with these anyway. Won't get into them too much. Okay, so full remission. When are we thinking about discontinuing medications? I'm starting to say this too many times. So completely symptom-free for a year. We want to see them enjoying at least 3 activities that they'd stopped with depression. Their relationships, family, work life, all of that stable. They're withdrawing from, we're always going to withdraw from medication slowly. These aren't meds that we want to go cold turkey on. Though I can't tell you how many times I've had a woman under new OB tell me that she just stopped all her medications. So that's something I like to particularly watch for with our pregnant mamas. We want to make sure we're monitoring mood closely through the withdrawal period and review relapse criteria, and then reconsider seasonal and situational data as well. Cardinal sin of pharmacotherapy is stopping or switching meds too soon. So if we're not feeling better in 4 weeks, that doesn't mean it's time to switch to a new med right away, right? So starting low and going slow. Final things to ponder for depression. It really is a medical illness, not a character defect. Recovery is the rule, not the exception. Many treatment options with effective treatment for nearly all patients, so we have a lot of options. Aim of treatment is complete symptom remission, not just getting better, but getting and staying well. So thinking about that pursuit of health, not just the absence of disease. Significant risk of recurrence makes recognition of early signs and symptoms by patient and family critical. I think of this especially when you have a woman who has a history of depression and she's pregnant and she's not currently depressed, but we're gearing up for postpartum and realizing that she's going to be at a pretty high risk for a relapse, right? To just review with her, what are her triggers? What are her most common first signs? Is it that she's not getting out of bed as much in the morning? Is it that she goes from showering every day to every other day? Nothing wrong with showering every other day, but if your normal is every day and that helps you know that you're starting to head in a different direction, making sure that she's being able to recognize those early signs and that people around her are also able to help her recognize those early signs. Okay. So I'm not going to touch on bipolar disorder for very long, but let's just make sure we have at least a good overview. So bipolar 1 is at least one episode of full-blown mania, as well as having the depression side. And then bipolar 2 is having hypomania rather than a full-blown mania. So, so abnormally elevated mood, might be expansive, might be particularly irritable. Full remission is not common, but it's possible. So in general, we're going to be on constant meds, is what I'm saying with that. Okay, bipolar 1. So acute phase would have the manic, psychotic, poor judgment, suicidal element to it. And here's oftentimes where we find out that what we thought we had was depression, but what we really have is bipolar disorder. SSRIs will trigger a mania. So if somebody's depressed and we give them an SSRI, they should get better. But if what they really has is a depressive side to their bipolar, SSRIs are going to swing them over into mania. And if this happens to you, that's an immediate referral. Okay, and then continuation phase. So we have an acute phase and we have a continuation phase. So symptoms and function are partially improved. And then want to just think about ongoing maintenance when we're in a good place. And then in general, lithium is going to be your drug of choice. So there's a lot of different mood stabilizers out there. And I'm choosing not to get into all of them in this lecture. But we'll go over lithium at least briefly here. And okay, so then bipolar 2, depressed phase, and then hypomania, decrease in sleep time, and again, SSRIs might worsen it. And then mood stabilizers are going to be our drug of choice. And you could consider adding another mood stabilizer or an antipsychotic as well for bipolar disorder. So I don't know how many of you will end up treating it yourself. I think if it's an area of interest for you, surrounding yourself with good mentors, and I mean this is certainly within a midwife's scope of practice, though I think more commonly I see people referring. But if nothing else, you have a woman who's pregnant who's in your care, and being familiar with the medications and being familiar with the general trajectory is helpful. since you are her primary care provider and overseeing her care in pregnancy. Okay, so lithium, there's your typical dose. Typically it's divided out. Need to be keeping up on BUN, creatinine, and TSH. EKG if she's over 40. Side effects, nausea, diarrhea, dizziness, feeling dazed, fatigued, muscle weakness, dry mouth, weight gain. So lithium's not an awesome drug in that department. Let's see. Yep, and when it's first initially given, you need to draw drug levels after 12 hours. And mortality is about 25% with toxicity. So this is definitely a start low and slowly increase. So you can see the range of where we want the drug to fall. And it's not that far over that we reach toxicity. So it's a drug we need to be really careful with. Great, and just to be aware, elderly, tons of interactions with other drugs they might be on, so something worth looking up. And then other examples of mood stabilizers are at the bottom there. Yeah, and for Equetro, as well as Lamictal, those can decrease COC efficacy. So just something to be aware of. Okay, so this could have used a full lecture all on its own, but I'm just going to give us a brief overview. There's so much that we can do with integrative medicine and non-pharmacologic treatment options, both for promoting women's mental health as well as for helping them overcome depression and anxiety. So SAMI and St. John's wort, oh goodness, there we go. SAMI and St. John's wort are two that I decided to highlight from more of the natural perspective. So SAMI, there's a typical dosing for you there. There's been multiple randomized controlled trials showing that it does help with depression more so than placebo, and then other randomized controlled trials that compared it to TCAs, and they were found to be just as effective. SAMI is typically just done for a short duration, like 6 weeks, and then you could augment it with an SSRI or an NRI, and that would improve remission rates. So just something to think about, something that you could augment on to what you're already doing, or something you could experiment with doing on its own. Okay, and then St. John's wort, typical dosing you can see there. So basically, here's what the randomized control trials say on St. John's wort. If it's just kind of mild to moderate depression, then it has been shown to be really helpful. But if we're talking MDD, it doesn't touch it. So if we just kind of have a hint and we're headed in that direction, and somebody's really opposed to being on, say, an SSRI, St. John's wort could be something that you would consider. I occasionally will have somebody saying that they got some dry flowers or leaves and they're like occasionally sipping tea with it. That's not really going to do anything. So it needs to be consistent. Same with SSRIs and all the other drugs aimed at helping with depression. It needs to be consistent and regular throughout their day for an extended period of time before they would really see a difference. So something they could consider. But also what we really need to know about St. John's wort is that it can interact with SSRIs as well as OCPs and hormone replacement therapy. So if any of that other kind of stuff is happening, we don't want to be on St. John's wort. So a lot of drug interactions. So definitely something you need to be aware about. And something worth asking about. So you might be starting someone on an SSRI. You've established that we're depressed and you've gotten her medication history, and she didn't think to mention she's also been trying St. John's wort on the side for a while. Anyway, so something to think about there. Exercise, fantastic prevention strategy for depression. Multiple studies have shown that, especially like if women have somewhat high Edinburgh postpartum depression scale scores initially postpartum. There's been randomized controlled trials having some of those women, well, I think I just seen one. So some of those women going and having like an exercise routine, and then others just continuing with whatever else they were doing postpartum. And it was significantly decreasing their EPDS scores. So that's pretty cool. But then also on its own, I know I saw one study that was comparing, I don't remember, I want to say it was Prozac. It was an SSRI that was comparing exercise plus fish oil to an SSRI, and they were basically equivalent. So, and it didn't need to be extreme exercise, just like walking for a half hour to 45 minutes every day, along with, I think it was 2,000 milligrams of fish oil in that particular study. So I don't have a citation for that there. Yep. So just something to really be encouraging in women who are depressed. Not that you're doing it instead of like an SSRI, but either way, something you could add. What else to highlight here? Yeah, decent research around acupuncture, aromatherapy. There's been a few different oils that have been particularly tied to being helpful with both depression as well as anxiety. So depression, I know, like bergamot, frankincense, lavender, lots of tie over. Lavender would be great for anxiety as well. Clary sage, lang lang, and nowadays there's quite a few mixed blends that people could get that are already ready to go, whether that's Young Living or doTERRA or what have you, that have like pre-mixed blends that can be really helpful for women. Yeah, so that would be an option. Bright light therapy, certainly if it was seasonally tied, and certainly if you're in Minnesota. So that would be a great option. And group therapy, absolutely. I feel like some of that should have come up more previously too. Cognitive behavioral therapy. Basically, studies are very clear that cognitive behavioral therapy plus medication will have greater efficacy than a prescription alone. And in the same way, the combined versus just cognitive behavioral therapy combined is better than the therapy alone as well. So to really have the two of those pieces being your staple for therapy is wise. So counseling, I guess that would be the overarching term for a lot of that. Deep brain stimulation and ECT, so lots of other options there, whether you're using them instead of or as adjunctive therapy. And if you're using it instead of, then you want to think about what's the severity of what's going on. So, great. And then just really wanting to emphasize that mental health is foundational to health. It really impacts your health. So, like a woman who's depressed, how well is she feeding herself? How good a job is she doing of getting out and exercising and getting good sleep at night and taking care of herself with hygiene, for example. So to think about health is really being fluid between social health and physical health and psychological health, emotional health, that all of those affect each other. And just as being depressed or being anxious would impact your physical health, having something wrong with your physical health can also impact your mental health. So for us to be really mindful of where people are at mentally helps us to be able to really care for them holistically. All right, have a good week, everyone.